Good morning, and welcome to our TED-Style Talks. I'm Jodi Hoffman, medical geneticist at Boston Medical Center, and this year's program committee chair. I'm excited to introduce you to our speakers. Today, we bring you three experts at the forefront of integrating the practice of genetics with ethics. They will speak about the inherent tensions between medical professionals' desires to treat and patients' ideal treatment, and cultural sensitive care. Dr. Holly Tabor, director of the Stanford Center for Biomedical Ethics, will explore ethical challenges regarding the professionals' roles in diagnosing and treating genetic conditions that include disabilities. Dr. Lauren Maucere, curriculum and outreach supervisor at the California School for the Deaf, Riverside, California, will discuss her experiences as a deaf woman and educator, insights from living within the deaf community, and perspectives on current medical interventions for hearing. Dr. Grace Meier, a family medicine physician at the Clinic for Special Children, Lancaster, Pennsylvania, will share her experiences providing culturally sensitive care to the Plain community, emphasizing the need for community partnership that respects cultural values. Our speakers hope to bring you a thought-provoking session that helps medical professionals consider the balance between professionals' goals and patients' needs to foster a symbiotic relationship in the genetic and genomic care realm. None of our speakers have relevant disclosures today. I am pleased to welcome Dr. Holly Tabor.
Thank you very much, and thank you for the opportunity and the invitation to speak with you today. So I'm going to start with a show of hands. And I have some interesting predictions of how this will go. Please raise your hand if you know somebody personally or someone in your family who identifies as having a disability. Great, that's a lot of people. Okay, lower your hands. Raise your hand if you yourself identify or have identified as someone with a disability. A lot fewer hands. Okay, I think that's really important to keep in mind. The statistics show that most of us will be in at least one, if not both, of these categories in some time in our lives. And I want you to think about that and keep that idea in your head as I go through my talk this morning, and probably my colleagues' talks as well. I also want you to keep in mind the metaphor of a kaleidoscope. So some of you may have had a kaleidoscope as a child, or if you have children, they may have had it. It's usually a cylinder, it has two mirrors, it has a collection of colored glass, and when you hold it up to a light and you turn it, the glass reflects back on the mirrors and through the light to create a series of beautiful patterns like the one you see in this slide. And if you rotate the kaleidoscope, the patterns change and you see a different beautiful pattern. And I want you to hold that metaphor as we think about how we interact with patients, particularly patients and research participants who have disabilities, and how we can kind of tilt our kaleidoscope lens so that we can see the different patterns that they reveal to us that may look different than the details from just looking, for example, at a pile of glass as opposed to glass through a kaleidoscope. So I'm going to tell you a story about a patient. This is actually a picture from inside of our hospital. This patient is a 25-year-old woman, Ms. K. When she was 18, she was in a terrible bus accident and suffered multiple traumatic injuries. She had a bolt come through her abdomen and pierce her abdomen and her uterus. She had multiple fractures. She did actually recover after a very long hospitalization and rehabilitation course, but she's presenting at the hospital today at age 25 with a miscarriage at 8 weeks of pregnancy and with significant clinical symptoms of depression. And I would also say that in her life, she's also, even though she's recovered, she has significant disability and pain resulting from her injuries in the bus accident. So this is a visual description of this patient, actually painted by this patient, and this patient is the artist Frida Kahlo, who many of you may be familiar with. And this is her piece that she painted in 1932 after her miscarriage and hospitalization, called Henry Ford Hospital. And you can see in this painting many vivid images of how she experienced her pregnancy and how she experienced through the lens of her disability and her pain. And this is a really different kind of expression of what it felt like and what her experience was of being a disabled woman going through this miscarriage and going through this difficult time in her life. I saw this painting at exhibit in Boston, the Museum of Fine Arts, a few years ago about Frida Kahlo and her inspirations, and I learned that she was inspired by a form of Mexican folk art that was popular in the late 19th and early 20th century called retableaus or ex-votos. This is an example of a retableau or ex-voto painting. They were paintings that were done on tinfoil pieces of tin that were rectangular and approximately this big. Common people, ordinary people, usually paid artists to create these, and they used it to commemorate and give thanks or even ask for divine intervention to try to help with some kind of tragedy or some kind of medical crisis. And retableaus traditionally had three components, some of which you can see in this example. One is a picture of the event, whether it was a health event or some kind of tragic accident. Sometimes that picture showed the healthcare professionals trying to help the person, as you can see in this picture. The second element, which you can see at the top left, is the divine intervention, often a picture of an angel or someone who either the person who commissioned the painting thought intervened or wanted to hope that they would intervene. And the third element, which is not present in this example, is usually a piece of text actually explaining what happened and giving thanks for whatever the intervention or the outcome was. And these examples were very inspirational to Frida Kahlo. This is an example of what happened in Mexico. So people would commission these paintings and then they would leave them outside of churches to sort of commemorate and give thanks for the intervention that they thought that they or their loved ones received. And this is an example of a lot of retableaus hanging up outside of a church. Frida Kahlo was very inspired by this form of art. This is a picture from inside her home. She collected over 2,000 paintings of retableaus, and it really influenced the way she represented herself, her healthcare experiences, and many of the other figures in her art, if you go back and look at her art. And I want to reflect a little bit on how we think about portraying the stories of patients with disabilities, in particular in the context of genetics. Many of us know very well the pedigree as a way of explaining inheritance. This is an example of a classic PKU pedigree. You see circles and squares filled in or not filled in with lines and structures to help us understand inheritance patterns, right? But there's really not much in this that talks about the lived experience of, in this case, living with PKU. This is another example that I actually picked up off of eBay from a genetics textbook from the 1970s of another way that genetics and the genetics profession talk about the stories and lived experiences of people with disabilities. Here you can see pictures of people's faces and people's bodies, but again, there's really nothing about what it's like to live either medically or socially or any other aspects of life with a particular condition such as the one displayed here. And this is a very different example, which I think drew me to this example of Frida Kahlo and retableaus and ex-votos, which is from social media. Shane Burkaw is a young man who has spinal muscular atrophy. He also has a nonprofit, which I've shared a link with at the end of my talk, and he has a very significant social media audience. And a number of years ago, he started posting about his decisions about whether or not to pursue gene-targeted therapy for spinal muscular atrophy. And he talked about his values. He talked about wanting to preserve his functional independence as much as he could. He actually took videos of his experience receiving treatment. And in that way, he was able to talk not only about his lived experience and shed light on what that decision and what the impact on his life was and would be, but also about his values and how providers could understand his values in their context when they were trying to take care of him. We did a research study that was published interviewing patients with spinal muscular atrophy about their decisions to pursue gene-targeted therapy. And one of the patients was very memorable for us. She was in her 40s, and she was saying that unlike Shane Burkaw, she decided not to pursue this treatment. And this was because as a wheelchair user, for her, the higher impacts, the more important things were things like being able to have a motorized wheelchair, being able to have an accessible home, being able to have the kind of home care that she needed. And when she weighed the cost and the challenges of needing to get particularly the gene-targeted therapy that was available at the time, she didn't see that as being worthwhile to her in her value system. And what she said was, lifetime it would cost her $8 million. Why would she spend $8 million just to be able to open the heck out of a Ziploc container? So I think about her and her perspectives a lot, and thinking about how we need to hear patients' stories when they're thinking about the different trade-offs. So how can we hear these stories? How can we think about them both in our practice and our research, but also in our clinical care and as humans in society? These are just 3 brief examples I wanted to mention. The first one on the left is a book by Kelly Cervantes about her experience as the mother of Adelaide, who was her daughter, who had a very severe form of epilepsy and unfortunately died at a very early age. Kelly writes a wonderful, powerful memoir about that experience of caring for her interactions with the healthcare enterprise, particularly when the cause of her daughter's epilepsy was not known. Kelly and Adelaide and their family were part of the Undiagnosed Diseases Network, and a few years after Adelaide died, they actually identified the gene that caused her condition, and Kelly has written a blog post that I've also included a link to, talking about how that didn't change her experience of being Adelaide's parent and thinking about the benefits of genetics for people with different kinds of disabling conditions. The second picture is from a wonderful documentary I love called The Power of Two about Isabel and Anna Stenzel, who were twins who had cystic fibrosis, who both benefited from lung transplants. The film is about their experience with that and talking about some of the benefits that patients with cystic fibrosis were able to receive in the last 25 years that prolonged their life and improved their quality of life. But it also talks about the dimensions of what's hard about that, about how obviously lung transplants and many of the other treatments aren't magic solutions, and patients need still a lot of support and interaction from all of their providers, including genetics providers. And on the right is a story from the Peter Lurie Hospital, which I've also included a link to, of a young boy who has D1T1 dystonia. And if you have variants in DYT1, as some of you know, you're eligible and likely to receive benefits from deep brain stimulation surgery. And this patient was able to do that and ameliorated much of his disabilities resulting from his dystonia. But if you know anybody who has D1T1 dystonia, or you've treated anyone and has deep brain stimulation, it's not a perfect solution. There are only certain parts of the country that actually provide this intervention. Insurance doesn't always pay for it. You have to have a lot of checkups, and like a lot of neurotechnologies, we don't really know how long it's going to last or what kind of supports are going to be needed. These are the kind of nuanced stories about disabled patients that we as genetics providers and genetics researchers need to think about. So what are some of the challenges for patients with disabilities who also have genetic conditions or may have genetic conditions? Most people with disabilities experience significant barriers to healthcare. There's very strong empirical evidence that not only can they not get specialized healthcare, it's very hard for them to get basic healthcare. Many healthcare providers don't actually accept disabled patients into their practice, thinking there's some other special clinic for their regular healthcare, and many healthcare facilities actually aren't even accessible to people in wheelchairs. There are lots of challenges for patients with disabilities accessing services. This is only going to be worsened by the proposed threats to funding and Medicaid. I would argue, I was just thinking before this talk, that I think this is going to be one of the hardest times to be a disabled person in society in my lifetime. Many of the services that people absolutely rely on are being taken away, and many of them had limitations in the first place. You will see this in your clinic. You will see this among your research participants. And I think we have an ethical and moral obligation to hear those stories and to think about how we can help patients. Many people with disabilities and their families experience discrimination and ableism in housing, in employment, in voting, in pretty much every aspect of their life, in traveling on airplanes to get to conferences like this. That may not be something they volunteer up in their interactions with you, but it's something you should ask about and be aware of. And finally, not everybody, but many people with disabling conditions and their families experience isolation and mental health challenges. And there's a lot of stigma about admitting that, but I think recognizing that it's a challenge allows us to be more compassionate providers and researchers who are more in tune with the needs of our communities. But I want to highlight briefly the disability paradox, which is this idea that as presently non-disabled people, we tend to judge the quality of life of disabled people far worse than they judge it themselves. And there's many studies that validate this, that we may look at somebody with significant disability and say, oh, that's a terrible quality of life, no one would want that, they must have a terrible experience. And in fact, that's not what people with disabilities, even severe disabilities, often say. And in fact, they say that what affects their quality of life is their ability to interact with social supports and environmental supports. And we as researchers and we as clinicians can help them with that. So it's really important to be reflexive and mindful of our own implicit and explicit biases about disability, about what it's like to live with a disability. Recognizing what's hard, but also recognizing what's good and how we can support those people. Again, it's tilting the kaleidoscope so we can see different patterns. And I think we need to think not just about diagnoses, early detection, cure, prevention, and treatment. All those things are important. I've been working in genetics for many, many years. I think there's a lot of important, valuable benefits that come from that. But we have to think beyond that a little bit and think about how we can focus on our patients and what they define as a marvelous life and by their own criteria. This is a quote from my dear friend and colleague, Paul Miller, who passed away in 2010. He was a professor at the University of Washington School of Law and an EEOC commissioner. He had achondroplasia and Leigh-Fraumeni syndrome. And what he said in an interview before his death was, when I was born, I know my parents were scared. They looked down at this little shriveled child and they wondered what my life would be like. Would I play ball? Would I have friends? Would I be able to do the things they dreamed that their son would do? And I have played ball a little bit. I have always had fantastic friends. I've had good jobs. I've done a good job at them. Along the way, I have helped other people. I have a lovely wife and 2 beautiful daughters. I have had a marvelous life. And I just want my girls to know that everyone can and must live a marvelous life. And so I think our job is to try to help our patients with disabilities live a marvelous life to the best of their abilities as they define it, and use the tools that we have at our discretion to try to help them. So how can we do that? I have a couple of points. First of all, presume competence. Even if your patient looks like they have a communication disability or a cognitive disability such that you're not sure if you can interact with them, Google presume competence. There's a lot you can do to respect your patient, even if you think you may not be able to interact with them in the exact same way you interact with a non-disabled patient. Center the voices of disabled people. Listen to them. Hear about their perspectives. Don't think that what you've read about in a textbook or what you saw in a case in your training or what you read in a most recent article captures the lived experience of that person with that condition. Challenge implicit and societal medical biases about disability and disabled quality of life. I would argue that genetics can be at the forefront of this in medicine and at the forefront of this society. And at this point in time in history, it may be more important than ever for us to do this. Ally with disabled patients and communities to improve quality of life and patient-centered care beyond the clinics. Think about what kinds of letters you could write that could help them get access to services. Ask them. Ask them what they need. Ask them what's challenging in their life. Ask them what they're hoping for today. This is common in medical practice of what's trained that should be done, but far too often we forget to do it. I think it's incredibly important. I also think it's important for professional societies like ACMG to ally for disability communities and for people with disabilities. I really commend the board for having this session today, but there's still lots of concrete ways that professional societies can more intentionally and specifically follow best practices to support the inclusion of disabled people. Thank you very much for inviting me today, and this is a link that includes resources and detailed information to all the things that I talked about today. Thank you very much.
So my name is Grace Meier, and I'm a physician at the Clinic for Special Children. Today I'm going to be talking about culturally sensitive genetic care lessons from the Amish community. I have no financial disclosures. The Clinic for Special Children is a medical home for children and adults from the Amish and Mennonite communities with complex genetic conditions and other types of complex medical conditions. Since 1989, the clinic has been caring for the Amish and Mennonite community, known collectively as the Plain community. I started going to the clinic when I was in my intern year of residency, and on my first day, I went on a home visit and saw a patient with DeGeorge syndrome, whose parents were trying desperately to avoid taking her to the emergency department for fear of her already fragile mental health. In return, I received a case of peaches, and from that point, I never looked back. Today, I will be sharing with you lessons I've learned along the way caring for the Plain community. For 34 years, this was the Clinic for Special Children, a small timber frame structure raised the same way that the Amish raise a barn. In this 8,500 square foot building lived our interdependent clinical, research, and laboratory teams. While this setup can exist in large hospitals, it can rarely exist in a microcosm of only 36 employees. With less people and less red tape, we found it easier to create access for the majority of our self-pay patients. Highlighting the impact of our interdisciplinary team, in the last year, we've discovered 30 new disease-related genetic variants, tested 281 cord blood samples for conditions known to run in those families, and saw patients from 46 different states and 17 countries. This impact directly translated to the $13.3 million capital campaign, largely raised internally by the community. Our new building is now located in the heart of the Amish community in Lancaster County, Pennsylvania, occupying 3 times the space, all to serve the demands of our community. To think more specifically about our impact, we are best known for identifying glutaric aciduria type 1, or GA1, in the Amish community, and for the work of my predecessors on metabolic formulas and hospital protocols that have kept the vast majority of these patients free of permanent brain injury. We're also known for our work with patients with maple syrup urine disease, or MSUD, in the Mennonite community, from formula development to coordination of over 100 liver transplants and development of gene therapy with successful treatment of a bovine model and goal of treating humans, as well as trial of metformin for patients with obesity in adulthood in hopes of weight loss. In addition to countless hours in the office, in the hospital, on the phone, with these patients and their families, these are the reasons we have been able to earn the trust of these elusive communities. The first step to providing care to the Plain community is appreciating the history. Why are we this way? The Martyr's Mirror is a famous book found in many Amish homes about how Anabaptists were persecuted for their beliefs, namely their belief in adult baptism. Dirk Willem died in 1569, seen here in this painting, a famous Anabaptist who successfully escaped prison and was on his way across a frozen moat. Dirk was thin from prison rations and was able to cross the ice, but the guard fell through. Dirk turned around and pulled him from the water, and in turn, the guard pleaded that Dirk be let go for his good deed. Instead, Dirk was tortured and eventually died at the hands of the government. Some sources say that up to 5,000 Anabaptists were killed in the 16th and 17th centuries due to their religious beliefs. They all took scripture very literally, including in this painting, "Love your enemies." They used no weapons and refused to defend themselves when held captive, and thus had to become very self-sufficient. The next lesson I have to share is to learn your place in their hierarchy. Be humble. As we have learned from the Martyr's Mirror, the Plain community's response to persecution is self-sufficiency, to avoid the establishment. Going as far as championing publications like Be Your Own Doctor and disseminating community guides with recommendations on treating sepsis at home. If anyone in this room is seeing a patient from the Plain community, you can rest assured that they have made their way through this totem pole, and you are not the first provider that they have seen. It all starts at the health food store, and I'm not talking about GNC. Homemade tinctures and salves made of herbs, garlic, essential oils, and lots of onions are the basis of home remedies. Some have little effect, but others, like B&W ointment and burdock leaves, have been picked up by mainstream medicine and are used in burn centers across Pennsylvania. Depending upon the type of problem the patient is experiencing, a chiropractor, midwife, nutritionist, or brain therapist may be the next step. These are popular options in the community because they take the patient's concern and find a structural issue to blame them on. Parochial wellness centers are religiously affiliated primary care offices with little red tape regarding routine follow-up and are generally quite friendly to self-pay patients. House call providers are another popular option because patients can avoid the establishment. However, their training may be community-based, or if they do have training, they may not be in good standing with their governing bodies. Things generally turn around when these families come to the Clinic for Special Children because we're able to form a bridge between the community and the mainstream health system, relying on our relationships to support them through getting into the mainstream health network. Never assume. Shortly after starting residency, I learned that many of my co-residents and attendings were Mennonite. I started to feel like an insider, and I was pretty confident that Mennonites were definitely more modern than Amish. This just isn't the case. In fact, really one of the only things that you can assume about this community is that they're more likely to have a garden. Here you can see some parallel escalators, which I like to use to describe the communities. Both the Amish and Mennonite communities modernize continuously in parallel. From traditional or conservative to modern and progressive, they're continuously moving forward at the same time, but there are always groups of folks that are on each step. You can never assume if a family uses horse and buggy, hires a driver or drives a car, uses batteries in their home or has electricity, uses a landline or has access to a smartphone, accept vaccines, ventilators at home, or even gene therapy. It's never safe to assume, but it's always safe to ask. The Plain community is a high context culture. Shake hands and talk about the weather first. Here you can see a collection of Plain periodicals that I've put together and highlighted the comments about the weather. Coming from a busy family medicine practice, I had no time to chit-chat about the weather. So I had a really hard time getting on board with this concept. But seeing it in these publications really solidified the importance of the weather in this culture. Shaking hands is acceptable for both men and women, regardless of their gender. Drawing on comparison to our own low context culture, where bonds are fragile, accomplishment of tasks is valued far more than relationships, and reactions are outwardly visible, the key question to ask yourself to understand the context culture is, how much extra information is needed to understand what's going on here? In the Plain community, messages are implicit. Strong community bonds and personal relationships are far more valuable than tasks, and reactions are reserved and inward. So it's best to start things off on the right foot, shake hands, and talk about the weather. Everyone can understand something new if it's in relation to something familiar. If I were to start talking about a child with uncontrolled seizures and parents who were unwilling to give prescription medication, many of the people in this room would start to feel angry toward the parents and defensive of this child, and maybe even start to have a visceral reaction, like a pit in their stomach. But when I talk about the popular book, The Spirit Catches You and You Fall Down, which details our culture at odds with the Hmong culture over the care of Leah Lee, and you remember learning that the family believed that her seizures were caused by an evil spirit taking her soul, leaving her physically capable of becoming a shamanistic leader, and needing those seizures to negotiate on behalf of others' health in her community, you can start to understand and empathize with the family on how difficult this situation is regarding giving medication. Similarly, I've had to treat and tell families from the Plain community that their child has severe combined immune deficiency. When this news hits, the reality doesn't really sink in. And it's often the discussion that they need to stop breastfeeding that's the first thing to bring the family to tears. Breastfeeding is very important in Plain culture, not just for the transfer of immunity or the bond, but also for the cost and the logistics. Formula is expensive, and pumping for an infant, if you have 9 other children, is just nearly impossible. Analogies can be a big help here, and so remembering that these communities have an 8th grade education, often in a one-room schoolhouse, and speak English as a second language, it can be helpful to talk about how bone marrow is just like a garden and needs to be weeded prior to planting a crop in order to ensuring its success. Further, bone marrow transplant requires chemotherapy to clean out any of the old dysfunctional bone marrow in hopes of the new bone marrow being able to take root and grow a functioning immune system. Using analogies like these are really the key and the olive branch that can help these families feel more comfortable and help get on board with their new reality. Ufgiva is a Pennsylvania Dutch word that means giving up self and accepting God's will. In the words of one Amish mother, giving up self and accepting God's will is the opposite of me, myself, and I. It's what being Amish is all about. So when families with conditions like spinal muscular atrophy question if gene therapy will get in the way of God's will, know that this previously was all that they had to rely on when thinking of the children in the past that have suffered and deceased due to this condition. Or when a family is asking to be discharged at every interaction with you in the hospital, know that they are thinking of the other 10 children at home who are being cared for by one parent. Or when a family is planning a series of complex open heart surgeries for their baby with Ellis von Creveld syndrome, know that if they question if palliative care is a better choice, they are weighing the uncertain outcome for this child versus the funding for health care of their entire community. Make your follow-up plans in person. This is a phone shanty. The Amish and Mennonite communities keep phones out of their home to keep themselves separate from the establishment. Phones can be found in the barn, in a phone shanty, at the end of a driveway, or even in a phone shack that's shared by the entire community with joint voicemail. It's very uncommon to call an Amish family and get them on the phone. So if you want to connect with them, make sure that you make your follow-up plan in person, schedule phone calls. These families are very used to scheduling phone calls, being by the phone at the time you're going to call, or even calling in if instructed ahead. Further, phones may be in a drawer, especially if it's a cell phone. So the church accepts having cell phones for work purposes, but often these cell phones must be put away when that person comes home and are kept in the off position in a drawer. So it's never safe to assume that you'll be able to get a hold of a family just because they have a cell phone. In summary, it's important to take into account the history of this community and the persecution to understand the self-sufficiency. It's never safe to assume, and it's always safe to ask. Going forward, it's important to remember that these families have limited educational background, but exceptional life experience, and are able to understand complex concepts if only you take the time to form the relationship and continue working with them to take the best care of the patient. Thank you.
When I was 11 years old, I sat in our living room with my parents, watching a 60-minute special on a groundbreaking innovation, cochlear implants. My mother and father turned to me and asked if I wanted the implant. I said no. I was proud to be deaf, proud of who I was. Even at that young age, I knew that being deaf was not something to fix, but something to embrace. This belief was evident in an assignment I wrote about myself in 1985, where I made sure everyone who read it knew I am deaf. Even as a child, I accepted my deafness as an integral part of my identity, and that acceptance was nurtured by my parents' unwavering confidence in me. They believed I could do anything I set my mind to. I was born into a hearing family, my mother a nurse, my father a physician. I have a twin sister and an older brother, both hearing. I became deaf at 1 year old due to spinal meningitis. I grew up learning sign language, attending speech therapy, and participating in a deaf education program within a general education campus. My world was a blend of both hearing and deaf communities. But my perspective changed forever when I traveled to New Zealand for the 1989 Deaf Olympics, the deaf equivalent of the Olympics. There, I met thousands of brilliant and talented deaf people from all over the world. I realized something profound. Deafness is not a deficit, it's a cultural identity, a way of life, a source of strength and a thriving community. And yet, here we are today, standing at the crossroads of science and identity, where medicine offers the power to cure deafness. Well, I am here to name the elephant in the room: the power to potentially eliminate an entire community. Medical professionals take an oath to do no harm. But what does harm mean? When a child is born deaf, many doctors view it as a medical condition, something to be treated or fixed. But deafness is not an illness. It's a culture with its own language, history, and traditions. So I ask you, who decides what needs to be fixed? Does medical advancements always equal progress? And how much influence should doctors have over decisions that define identity, language, and belonging? When my parents were trying to figure out how to raise me as a deaf child, they were guided by many experts: scientists, doctors, audiologists, speech pathologists. However, many of these professionals had no lived experience with the deaf community, no cultural competency training, no real understanding of what it means to be deaf. Thankfully, my family sought out deaf adults who were thriving and who used sign language, who then became inspirational guides in raising me. When I use the term deaf, I refer to the diverse identities within the deaf community: those who are deaf, hard of hearing, deaf blind, deaf disabled, deaf plus, and late deafened. Each of these individuals leads a fulfilling life based on their own lived experiences. Yet, the experts that my parents consulted believed that the best way to help me was to assimilate me into a society designed for, quote, normal people. In other words, a society built around spoken language and auditory communication. This is where the bias came in. Bias is an invisible force that shapes how we think, act, and make decisions. It stems from societal norms, education, and personal experience, or the lack thereof. With bias comes audism, the belief that life with hearing is superior to life without it. With bias comes linguicism, the discrimination against signed languages, viewing them as inferior to spoken language. With bias comes ableism, the assumption that disabilities must be fixed for a person to live a full life. So I urge you to reflect. Have you ever made assumptions about deaf people without truly knowing them? Bias thrives in ignorance. The medical community, often with little exposure to deaf culture, makes decisions that profoundly impact deaf individuals and their families. So, how can this be changed? Well, by engaging with the deaf community, by asking questions, by learning some sign language, by following deaf curators on social media, by recognizing that deafness is not a defect but a vital part of human diversity. Think about this. If one species becomes extinct in an ecosystem, how does that impact the entire chain of life? Drastically. We need deaf people on Earth. Dr. Dirksen Bauman and Dr. Joseph Murray coined the concept of deaf gain, the idea that being deaf is not a loss, but an asset to society. Deaf people have made immense contributions to the world. Juliet Gordon Low founded the Girl Scouts of America, who was deaf. Deaf Smith was a key war hero in the Texas Revolution, who used his peripheral vision to help win the war. Dummy Hoy pioneered hand signals in the game, which we use in Major League Baseball today. The huddle you see in the NFL originated at Gallaudet University, a university for deaf folks, in fact, the only one in the world, located in Washington, D.C. Andrew Foster established many schools in Africa. The 1988 Deaf President Now movement led to the 1990 Americans with Disabilities Act. In the field of architecture, deaf space design principles enhance accessibility for everyone. Thomas Edison, a deaf inventor, gave us the light bulb. And Marlee Matlin, the first Deaf Academy Award-winning actress, led efforts in Congress for captioning accessibility. Now I'm going to show you a scene from ABC Family series called Switched at Birth. The video clip showed a classroom of deaf students where they were posed a question about being deaf and their value for it, their deaf identity, as well as living within the deaf community. They were asked if they could take a pill and wake up as a hearing person the next morning, would they do so? The answer was, of course, no from these students. Now, let's move on to my next slide, the greatest irony. A multi-billion-dollar industry promotes sign language for hearing babies because research shows early exposure to visual language increases IQ and EQ. Yet, deaf babies worldwide are being denied sign language because our so-called experts claim it won't be beneficial to them. This contradicts decades of research. The issue? It goes back to ignorance and bias. As a result of this bias, there is a global epidemic of language deprivation among deaf children, not because they are deaf, but because of bias. Gene therapy is a cutting-edge technology with the potential to cure genetic deafness. But with scientific advancements come ethical dilemmas. Parents make medical decisions for their children, but how can they make a choice that fundamentally will shape their child's identity without that child's input or these parents not having all the information about signed language and what the deaf community can offer? Statistics show that approximately 95% of deaf children are born to hearing parents, most of whom have little to no experience with deaf culture, deaf people, or signed language. When presented with a medical recommendation, what decision are they likely to make? Is this truly informed choice, or is it being informed by medical bias, the assumption that hearing is superior? Informed consent must include more than just medical risks. It must consider cultural, ethical and identity-based consequences. Now, it's important to approach care through an affirmative lens, showing respect for deaf identity. Acknowledge that deafness is not solely a medical condition, but a cultural and linguistic identity, including recognizing that ASL is a fully accessible and legitimate language. Provide qualified interpreters. Ensure access to professional interpreters in all medical and research discussions. Informed consent with cultural awareness. Present information about gene therapy with an understanding of deaf culture and identity. Inclusion of deaf professionals. Involve deaf researchers, medical professionals, and community advocates in decision-making. In terms of family and community education, offer resources that help educate families about deaf culture, signed languages, and the full range of identity-affirming options. Next, we want to ensure patient autonomy. Allow deaf individuals and their families to make truly informed choices without pressure or bias. Provide accessible genetic counseling. Do so that includes ASL support and cultural competency training. We also have to consider ethical considerations in our research. Engage the deaf community in these discussions regarding gene therapy's impact on culture and language. And have a commitment to language acquisition. Support bilingual, whether it's signed, written, and spoken language acquisition, regardless of medical interventions. So, would my life look different if I had chosen to get cochlear implants? Probably. Would I feel the same sense of purpose and belonging? Probably not. Being deaf has given my life meaning. It has connected me to a global community, a rich cultural heritage, and a profound sense of identity. Would I trade that for the ability to hear? No. Because if I had, I would have never met my husband. We have been together for 30 years and have 2 amazing children. My husband, John, comes from a 3rd-generation deaf family with a 4th generation after him. For many deaf families, their identity is woven from the fabric of their heritage, just like other cultural and religious communities. Imagine if we had chosen medical intervention. How would that have impacted our family, our community, our place in the world? Let's go beyond the personal now and consider broader implications. Gene therapy is still experimental. What are the risks? Who will have access? Will this technology create new disparities? Will society pressure deaf individuals into conformity, further framing deafness as a problem to be fixed? Will the decline of signed languages erode the foundations of deaf communities? So I ask you, are you presenting parents with all of the facts, including the value of deaf culture, having an accessible language and community? Are you framing deafness as something to be fixed or something to be understood? The future is not about choosing between science and culture, it's about blending them. Let's ensure that as technology advances, humanity does too. Being deaf has shaped my life. It has given me purpose. It's who I am. And I hope that after today, you have a deeper understanding of why the deaf community is a vital part of humanity. So, with that, let's celebrate deaf children at the California School for the Deaf at Riverside, where there are no limits. So please take a moment, everyone, to collect resources using your camera phone by scanning the QR codes. Thank you all for your time and for having me here today. It was a pleasure. Thanks, everyone.